Um, Thank you very much for asking me to come and talk about drug reactions. I'm not a pharmacist, so I want to say that first of all, and really the way that I've designed this talk is to give you a more practical approach to your patient that you see in clinic who might have an adverse drug reaction in TB treatment. So I'm going to talk about why it's important, the different mechanisms of adverse drug reactions and which ones are common, give you a practical overview and talk a little bit about individualised treatment and monitoring in the future. So, why is it important? There was that amazing programme that BBC4 did last week on MDR-TB, and one of the patients was a builder, and he said, if I could build death, then I would have built it by now. And that wasn't necessarily just in response to his multi-drug resistant TB, it was in response to the side effects that he was experiencing due to the medication. So people stop taking treatment if they feel unwell taking it, and often they can feel more unwell taking treatment than they did in the first place. And that can, as we've heard from Onmin, increase your risk of developing drug-resistant disease. It also impacts on your drug selection, and again, that can increase your risk of drug-resistant disease because if you have to remove one of the most effective drugs, particularly rifampicin or isoniazid, due to drug reactions, then you're moving into the drugs with less efficacy. Causes interruption to therapy, which increases the cost of treatment because you're increasing durations, increases resistance, I mentioned before, and prolongs the treatment duration, which patients don't like. Adverse drug reactions also cause significant morbidity and mortality. We've had a couple of cases who have ended up requiring liver transplants and even have died due to hepatotoxicity. So it's not to be underestimated. And it also prolongs hospital stay, which can cause, which causes increasing costs as well. So we all know the first line antituberculous treatment. I'm not going to talk about adverse side effects to second line treatments because I think we're going to have a talk about that later. I think one thing I do want to mention here is moxifloxacin is being used a lot more frequently alongside these drugs, and QTC prolongation is something that lots of people are very worried about, and there are some guidelines for the use of drugs in multi-drug resistant TB, which I think Will's going to point you towards later. So we've talked a little bit about Onmin mentioned where all of the baseline drugs affect the life cycle of TB, and that's just a slide for the scientists out there who want to know whereabouts in the cell wall they have an action. There are two different, or when talking about kind of pharmacokinetics and adverse drug reactions, you can split them into actually lots of different types, but the main two are type A and type B. One is predictable from the drug and is related to its pharmacology. It's dose related, it's common, it's normally reversible, and is usually managed with dose adjustment. And the type B is not dose related, it's unpredictable, uncommon, and might be serious, irreversible, and the drugs need to be stopped. So, common adverse drug reactions. Can anyone shout, I've already given you a clue, can anyone shout out some of the most common ones that patients might experience? Otherwise I'll pick on people. Nausea, great. Diarrhea. Itching. So diarrhea, certainly, vomiting and nausea. These can be caused, nausea, diarrhea, vomiting, by any of the drugs, but most commonly rifampicin and isoniazid. You said itching. What's this? This is purpura, thrombocytopenic purpura. This is your typical maculopapular drug eruption rash, flushing, very, very common, and also photosensitivity, all of which can be caused by, in particular, isoniazid can cause any of the three on the left. Pyrazinamide often can cause photosensitivity and flushing, and also a drug eruption. We see quite a lot of patients who have drug eruptions secondary to pyrazinamide, and rifampicin can cause thrombocytopenic purpura. What's this? It's hepatotoxicity. Often patients will be asymptomatic, but they may develop nausea and vomiting due to hepatotoxicity, or sometimes you might see jaundice. Peripheral neuropathy and arthralgia, also common complaints. And actually, patients don't tend to complain of colour blindness. They tend to complain of blurred vision if they complain of any visual disturbance. So isoniazid causes peripheral neuropathy and can cause arthralgia as well. Rifampicin, isoniazid, and pyrazinamide can all cause hepatotoxicity, and ethambutol, pure visual disturbance. So how do we manage patients when they do have these drug reactions? I think it's worth thinking about in four main steps. One is pre-treatment optimization. So who's most at risk? The second is monitoring. Third is treatment interruption and how we manage that. And the fourth is symptom management. So I'm going to talk about each of those. So risk factors for pre-treatment evaluation are all listed here. It's really important to ask about patients whether or not they've been previously treated for TB, aside from increasing your risk of multi-drug resistance. If you previously had a drug eruption to an allergic reaction to pyrazinamide, introducing it again could A, cause anaphylaxis, and B, will make your patient pretty unhappy. The older you are, the more likely you are to have drug reactions. The more drugs you're on, and particularly ones that are hepatotoxic in themselves, has an impact. Co-infection with hepatitis B and C. We've recently looked at all of our cases over the last year, and we've got a 2% co-infection rate of hepatitis B and C. They're also very common imported diseases like tuberculosis, and increase your risk of hepatotoxicity dramatically. Same goes for HIV. Malnutrition increases your risk of drug reactions. Pregnancy, pre-existing liver or renal dysfunction, and ethnicity. I'm going to talk a little bit about that later. So we do some baseline blood tests, liver function tests, hepatitis B and C screen. For those who, like me, always have to think about which tests of those we have to do, it's generally hepatitis B surface antigen and hepatitis C virus IgG. Using these, HIV test and a drug history, including opiates. And the reason I mention and oral contraceptives, the reason I mention both of those is because rifampicin has an effect on your cytochrome P450. It's an inducer, and that reduces the effectiveness of oral contraceptives, something that TB patients won't necessarily bring up on by themselves, and can often feel embarrassed about talking about, and it's important for us to warn them of the risks of reduced effectiveness of their contraception. With the opiates, you need to liaise with your local drug and alcohol teams, particularly when starting and stopping treatment, because if your patient is on methadone or using heroin, or your patient is in pain and using opiates, then if you put them on rifampicin, when you come to take them off the rifampicin, then your effectiveness of methadone will go up dramatically. That can actually kill people. So it's really important to liaise with the Drug and Alcohol Service so that you can manage the doses of methadone effectively. So with treatment interruption, you need to balance what the adverse drug reaction is with the risk of that to your patient, with the risk of treatment failure or developing resistance. So have a really good think before you stop treatment and restart it. There's a number of different methods of treatment interruption and reintroduction, and I'll point you towards where you can find them. There's different evidence for different regimens, and a bit like the treatment for isoniazid resistant, you need to pick what you feel is right. It'd be good if we could have the same strategy for everyone, but we don't. Consider reintroducing things at an incremental dose. I mentioned before the two different types of drug reaction, A and B. One of them is dose-related, so you can slowly reintroduce the dose as it's tolerated. If you have a patient who has a really severe reaction to the drug, you should really avoid reintroducing it if at all possible, because it won't make your patient more happy or more adherent to future medication. So just a brief word about hepatotoxicity. As I said, it can be caused by any of the three, isoniazid, rifampicin or pyrazinamide. It's often asymptomatic and transient, so we do LFTs at 2 weeks, and if they haven't increased by a significant amount, we just need to repeat them to make sure they're coming back down. It can be very severe, as I've mentioned before, and increased in elderly alcoholics, those with underlying liver disease or complex drug regimens, and HIV co-infection. And I talked about hepatitis and HIV screening. Oops. So this is one way in which you have a think about your patient with hepatotoxicity, think about whether or not they're unwell or well, how high their LFTs have gone up, and then you can stop all of their treatment and work out an reintroduction regimen. If they are very unwell or they have drug-resistant disease or a high burden of TB, then it's worth considering different medications other than the baseline at that point. Wait for the reaction or the bloods to settle down before reintroducing, and think about which regimen you want to use. Sharma did a randomized controlled trial which compared a number of different reintroduction regimens with just restarting everything at once. It was underpowered, but it's one way. It didn't show any particular increase in toxicity associated with that way of reintroducing medication. BCS guidelines say do it slowly and a stepwise regimen. Or you can have a think about whether it's cholestatic or hepatocellular, and think about which drug is the most likely to have caused that reaction and reintroduce the others, and that one last. Symptomatic management can often prevent you having to stop any treatment whatsoever, and is really, really important. So antiemetics, antihistamines, think about the timing of medications. Traditionally, we've always said take all your medications before breakfast, but often you can get quite bad nausea on an empty stomach, and you can consider splitting up your drugs from standard Rifater. You can split Rifater into the individual medications and split the drugs throughout the day. Whatever helps the patient take them every day and not feel so unwell. Adherence is key. Just a quick word about pharmacogenetics. I mentioned ethnicity as an impact on your likelihood of drug whether or not you're likely to have an adverse drug reaction. There was quite a lot of talk at the Royal Society of Medicine Day last week on hosts' genetic responses to treatment and to mycobacterial infection and vice versa. And there's been a number of studies which show your responses to different medications vary depending upon your host genetics. And that can impact on your drug levels. And it may be that in the future we need to consider measuring drug levels a lot more frequently than we are doing now and tailoring our treatment to the individual. So some useful references. We've written a lot of guidance on adverse drug monitoring in multi-drug resistant TB, but includes all the standard TB medications. It'll probably be at that website at some point in the future, but I'll keep you posted on that one. There is also the MDR TB forum on the British Thoracic Society website, and on there there's some frequently asked questions and which talk about adverse drug reactions and how to manage them. And there's the European Respiratory monograph, which also gives some guidance on management of adverse drug reactions, which is very useful. Any questions? Good. Thank you.